And now we're going to turn to another member of the Halker Singh family. Rashmi Halker Singh, MD, is an associate professor of neurology, and she's the Headache Medicine Fellowship Director and is the co-director of the Mayo Clinic Headache Symposium at Mayo Clinic. With a neuroscience degree from the University of Pennsylvania, she went to med school at Wayne State University in Detroit before completing a neurology residency and headache medicine fellowship at Mayo Clinic in Scottsdale, Arizona, before joining the faculty. She has published numerous peer-reviewed papers, book chapters, and editorials, and has lectured around the world on migraine and other primary headache disorders. Additionally, Dr. Halker Singh is the online and social media editor of the Headache Journal, the official publication of the American Headache Society, and is an editorial board member of the American Migraine Foundation. She is interested in building professional communities using virtual platforms and is a moderator of the Women Neurologists Group and an admin of the Migraine Mavens, who knew there were Migraine Mavens, social media network for women headache medicine providers. And so as we're listening to this next presentation, just a tip, she does have slides. And so if you want to both see her and see her slides, you can use the active speaker view on Zoom, and that way you'll be able to see both. So welcome.
Thank you so much. I'm going to share my screen. Let me see if I can get this to work. Okay. Can you all see my PowerPoint? Perfect. So I'm going to get started. Thank you so much for having me join this morning. This is so exciting. As Kristen mentioned, I'm an associate professor of neurology at Mayo Clinic, and my passion is talking about migraine. So I'm really excited to share with you all some updates in our field because we have quite a bit. Let me see if I can advance. Did my slide advance? I want to make sure I got the right slide up. Okay, perfect. So these are my objectives for the next 15 to 20 minutes. We'll talk about the prevalence and burden of migraine. We'll also talk about how migraine is a complex neurologic event that involves multiple brain regions, and also talk about how our understanding about migraine pathophysiology has led to new treatment mechanisms as well. And we'll also end by talking about migraine advocacy and if anyone's interested in becoming more involved in migraine, what the opportunities are in that sense. Okay, so people come and see me because they have headache. And I want to begin by letting you all know that headache in and of itself is actually not a diagnosis at all. And there are over 300 causes of headache. When we talk about headache, what we're actually talking about are multiple different problems. And the actual diagnosis comes from something called the International Classification of Headache Disorders, which was most recently updated in January 2018. This is a diagnostic criteria situation that was published by the International Headache Society. And every single headache diagnosis I make comes from this book. If anyone's interested, you can Google it. It's available for free online. And everything comes down to what diagnostic criteria someone's symptoms best meet. And my job as a headache clinician is really to talk to my patients and to make sure that their symptoms don't suggest that they have a secondary headache problem. So, when someone comes in to see me, I'll ask them a lot of questions to clarify, is there something else going on that might be causing a headache problem? Is there a brain tumor? Is there an infection? Is there something else going on that causes a headache? And if so, we'll do investigations to look into that. And if there isn't, then I'll ask additional questions to clarify what I think their actual diagnosis is and treat that. And the vast majority of the time, what my patients have, actually what most patients have who come in to see a doctor with headache is migraine. So we'll spend a lot of time today talking about migraine. The World Health Organization has actually identified that migraine is the second leading cause of years lived with disability worldwide, and the leading cause of years lived with disability in women under the age of 50. And it is so much more than just a headache. This is a genetic neurologic disease that has headache pain as well as other symptoms too, right? So people can have cognitive symptoms, GI symptoms, vestibular symptoms, a whole host of different problems. And even though it's so common, it's very often misdiagnosed. People will come in to see their doctor and tell them that they think that they have tension headache or sinus headache, or cluster headache or even other problems. Or even doctors might give people these diagnoses. And, we'll go into a little bit more detail as to why this misdiagnosis happened. First of all, people sometimes think that they have tension type headache, and I'll ask them, why do you think that? And the common reasons that come up are, people will say, well, I have neck pain with my symptoms, or I've heard that migraine typically affects just one side of the head. And, my pain is on both sides of my head, or, my whole head hurts. Or, stress is a trigger. Doesn't that make this a tension headache? And the honest answer is none of those things will differentiate migraine from tension headache. Sinus headache. This comes up all the time. And actually, just this morning, I was part of a panel with some ENT physicians where we talked about sinus headache and how to co manage that. Most of the time, when someone thinks that they have sinus headache, what that actually is migraine. And people will often think that they have sinus headache because the pain is located over their sinuses, or maybe they might even have some nasal congestion, nasal symptoms with their attacks. Or sinus medication can actually provide some relief because it has a little bit of an anti-inflammatory component to it. But none of those symptoms will differentiate migraine from a true sinus cause of pain. Because I've, told you that migraine is so common, I think it's important that we're all on the same page in terms of what makes migraine what it is. So this is the diagnostic criteria for migraine, according to the International Classification of Headache Disorders. You need to have 5 lifetime attacks of head pain that last a minimum of 4 hours without medication, and the pain has to have at least 2 of the following 4 symptoms. It's more intense on one side, it can throb or pulsate, it's moderate to severe in intensity, and it's worsened by activity. Any 2 of those symptoms is enough to meet that criteria. In addition, you need to have either nausea or be sensitive to light and sound. It's easy to see looking at this diagnostic criteria how different people can have different types of head pain but still meet diagnostic criteria for migraine. And because I'll be talking about chronic migraine as well, I want to define that term also. Chronic migraine is defined by having headaches at least 15 days per month for at least 3 months. So again, you need to have head pain at least half of the time, and at least 8 days per month. Those headaches either need to meet migraine criteria or someone needs to take medication for it to keep it from getting to that point. Not only is migraine very associated with significant disability, but it's also very prevalent. There are over 1 billion people in the world who have migraine and over 47 million Americans who experience this problem. This is, about 18% of all women and 6% of all men. And that gender difference really becomes apparent after puberty and remains so till about menopause. And that has everything to do with hormonal differences between men and women, specifically estrogen fluctuations that women experience. And about 7% of people who have migraine will have chronic migraine. I think this is actually a really important slide. We've done epidemiology studies looking into migraine prevalence as well as barriers to care. The slide on the left, the chart on the left looks at episodic migraine and is data pulled from something called the American Migraine Prevalence and Prevention Program, the AMPP study. And they looked at people who have episodic migraine. And some important data that came from that study showed us that less than half of people who have episodic migraine even, will even see a doctor for their problem. And even when they see a doctor for their symptoms, only 40% will get an accurate diagnosis, and only a quarter of people who have episodic migraine will cross all 3 barriers of seeing a clinician, getting an accurate diagnosis, and getting placed on appropriate treatment. And if they have chronic migraine, that number of, seeing a doctor, getting an accurate diagnosis and getting placed on the right treatment is actually less than 5%. So there's a lot we can do to change things. And what I'm hoping to do today by speaking to you all and sharing about migraine is to really change that top number. I'm hoping by telling you more about migraine and what this condition is, more people will be able to identify migraine a little bit better and hopefully seek the appropriate care that they need. we know that migraine has a significant impact on quality of life. This is more data from the AMPP study. With this question, the AMPP researchers asked over 18,000 people with migraine, how are you usually affected by severe headaches? And over half of people said that they are severely impaired when they have a severe headache. And, the chart on the right demonstrates kind of what that means from a day to day standpoint. I want to just draw attention to a couple of things on that chart. First of all, about a quarter of people said that they will miss at least one day of school or work because of migraine. So that speaks to absenteeism. But even more than that, about a third of people will have something called presenteeism. And that's defined by the fact that you'll show up, right? You'll go to work, go to school when you have a migraine attack, but your productivity is reduced. So you're there, but you're not really there. So this is what we call an invisible disease, but that has real life impacts. And not only does migraine impact someone's work life, but it also impacts relationships. It can impact your relationship with your partner, your family life, and also how you parent. And, none of this is in a vacuum, right? So, if you're not able to, your relationship, if you have migraine and that affects your relationship with your partner, how you function in your family and how you parent, all of that's interconnected. And I think that's really easy to understand. When we talk about the burden of migraine, I think people typically think about the attack burden. So we think about, the disability associated with the attack itself. But I want us to think about something else, and that's the interictal burden of migraine. And that's the impact that migraine has between attacks. And many people who have migraine will tell me that even on days that they don't have migraine, it impacts their quality of life, right? Because this is a disease that's very unpredictable. And many people will plan their life, they'll plan their work life, their social life around migraine. And they'll think about, well, if I commit to this activity and if I have a migraine attack, will I be able to manage that activity? Will I be able to commit to that, whatever social event that I had agreed to do? And they'll plan accordingly. And a lot of people have anxiety about their next migraine attack as well if they don't have good treatment. There's even a word for that. It's called cephalalgia phobia. It's a real thing. And also, not everybody is completely free of symptoms between attacks either. Many people have lingering head pain or other symptoms. And when we talk about the total migraine burden and what we're targeting with our prevention treatments, it's all of this. It's the attack burden and also how people feel between their attacks. So let's talk about the phases of a migraine attack because there's actually multiple parts to this. Many people who have migraine will have the premonitory phase, and that really will precede the attack itself by hours to even a couple of days and can include things like fatigue or even neck pain. Some people will even have early light sensitivity or nausea before the attack even begins. Some people with migraine will have what we call the aura. Most commonly, that will consist of visual symptoms or even sensory symptoms. And by definition, that has to last anywhere from 5 to 60 minutes. This is followed by the headache phase that we just, talked about a few minutes ago. And many people will then go into this recovery phase or a postrum. This can last even up to a day or two. My patients will often talk about this as their headache hangover, where they're still kind of recovering. And then, the interictal phase is that whole time period between attacks. And as we mentioned, some people have symptoms even between attacks. I like this slide because we've done functional imaging of people during all of these phases of a migraine. And what we've realized is actually that the brain is involved from the premonitory phase onward. And this really is a neurologic disease that involves the whole brain. And I think this knowledge is very validating to a lot of people with migraine because this is a disease that's associated with quite a bit of stigma. So, what causes migraine? In the last several years, we've made some significant advances in our understanding of this whole disease process. We used to think about migraine as a vascular problem, a problem of blood vessel constriction and dilation, but that's actually no longer our current understanding. We know that migraine is a problem of pain transmission, and it's really a brain problem. It's no longer thought of as a blood vessel problem at all. This is a neurologic disease that has a genetic basis, and every meeting I go to, every paper I read, there's new genes that are, being implicated as playing a role in migraine. And when we think about migraine and how we can use that knowledge for treatment, it's really led to a lot of breakthroughs as well. So we know that migraine is this whole problem of pain transmission, and that knowledge has led to some new targets for treatment. One of these targets is something called calcitonin gene-related peptide, or CGRP, and based on this understanding, we've done a lot of studies on looking at these different treatment targets, and that's really led to a lot of breakthroughs. So migraine is this essentially it's a problem of pain transmission. This trigeminal ganglion, this trigeminal cervical complex, is a big player in migraine, and different parts are really being studied so that we can come up with some disease-specific treatment options for patients. And that's been really exciting because since 2018, we've come up with some really exciting new treatment options for our patients. In May of 2018, we came up with the first migraine specific prevention treatment for our patients. It's a drug called Aimovig that was quickly followed by two others called Emgality and Ajovy. These were the first migraine specific prevention treatments for patients that to become FDA approved. They really changed the way we look at migraine and treat this disease. And earlier in 2020, this drug called Vyepti became the first IV medication for migraine prevention. And earlier this year, Ubrelvy and Nurtec became FDA approved that also target CGRP for the acute treatment of migraine as well. So our understanding of migraine pathophysiology is really translated to real life treatment options for patients. And not only do we talk about, new drugs for migraine prevention, but there's a lot that we can do that doesn't involve medication. And I talk to my patients about this all the time. I talk to my patients about using their seeds for success when it comes to migraine. And this mnemonic talks about sleep. Because people who have migraine really do better with a regular, sleep-wake cycle and sticking to regular patterns, as well as regular exercise habits, eating well, not skipping meals, staying hydrated, keeping a headache diary because sometimes triggers are not really easily identifiable, and also stress management. And then finally, I want to leave you all with just, if you are interested in becoming more involved in the migraine community, there are multiple ways to do that. So, the American Migraine Foundation is the patient and advocacy wing of the American Headache Society. They're very active. There's so many different things that they're doing. If you're on Twitter, they're very active there as well. The Miles for Migraine group, they host well, before COVID, they were going from city to city to do an advocacy walk run event, and all of the funds went to raise money to help train more headache physicians, actually. I've got some pictures up from the Phoenix Walk. This year, everything is virtual. And they have one coming up next week. So you're welcome to, help support. The Coalition for Headache and Migraine Patients is also very involved with fighting stigma in migraine. And one way we do that is by being very, purposeful with our language and images that we use with migraine, because this is a disease that has a lot of stigma associated with that. And they published a headache and migraine language image guide, which is available for free download. Just Google it. You can download that for free. I refer to that a lot in my talks as well. And then the Alliance for Headache Disorders does a lot of political advocacy. So they have this annual event called Headache on the Hill, where they will go to Congress and really help, do a lot of political advocacy for people who have migraine. And this year it's also virtual, but usually it happens in February and people will go and they have, usually some sort of plan where they try to go and talk to Congress people to get things passed. So I will end my talk there, but I'm happy to take any questions.